Good morning, everyone. Maybe even afternoon or evening, not sure. Wherever you are, I'm here to help. So, today we're going to explore one of the most practical and often debated aspects of psychiatric care: how often patients should be seen. Well, this question seems administrative on the surface, but it touches on clinical risk and management, patient autonomy, therapeutic alliance, and healthcare resource allocation. By the end of this session, you'll be able to define clinical principles guiding visit frequency, analyze the pros and cons of frequent visits versus spaced appointments, debate the issue ethically and clinically using case-based reasoning, apply a step-down model of care to real patients. So the core principle is that not one size fits all. The first truth is we must recognize it's that psychiatry cannot be scheduled like a primary care follow-up. Every patient's journey is unique, influenced by their diagnosis, acuity, social support, insight, and capacity of self-management. Therefore, the question is never, how often should I see all my patients, but rather, how often does this specific patient need to be seen right now? Our visit frequency evolves as a patient evolves. Key factors influencing visit frequency. When deciding how often to schedule a patient, consider 6 domains. Diagnosis, like schizophrenia, bipolar, and severe depression, require closer follow-up than stable ADHD or mild anxiety. The acuity, active suicidality, mania, or psychosis demand weekly or even twice weekly visits. Stability. Patients in sustained remission can be safely spaced to every 2 to 3 months. Risk level. Assess for harm or self or harm of others, relapse potential, and substance use. The treatment modality. Medication only care often requires less time per visit, but tighter intervals during titration. Insurance and system factors. Unfortunately, payment models and availability often constrain clinical freedom, and you must learn to navigate these pressures without compromising safety. When to see patients frequently. In acute psychiatric illness, high-frequency visits, weekly or biweekly, are essential. Why? Because acute illness equals instability, and instability requires observation, adjustment, and trust building. We see patients more often when they're suicidal, manic, or psychotic. They're newly starting or changing medications. They're early in therapy and need engagement or motivation. And they're recently hospitalized or struggling with adherence. Frequent visits prevent decompensation and strengthen the therapeutic alliance. Your consistency becomes their anchor. The middle ground, monthly visits. Once symptoms begin to stabilize, we enter the moderate frequency phase, usually monthly. This is critical period. The patient feels better, but stability is fragile. During this stage, the goal is to fine-tune medication, reinforce adherence, and coordinate psychotherapy. You're balancing two roles: supportive clinician and cautious gatekeeper. Too few visits risk relapse. Too many foster dependence. Monthly is a sweet spot for collaboration and calibration. Low frequency visits, maintenance, and recovery. When a patient has maintained stability for 6 months or longer, visits may extend to every 2 to 3 months or more. This does not mean disengagement. Rather, it represents trust in the patient's self management. Use this time to emphasize long term adherence, early warning sign recognition, collaboration with the primary care and therapists. This model reflects recovery oriented psychiatry, where independence is the ultimate goal. Non clinical influences. The most difficult part of things is payment. It's important to acknowledge that our ideal clinical scheduling often meets real world barriers. Insurance companies may deny reimbursement for frequent visits. Provider shortages lead to limited availability, and some patients cannot afford copays or transportation. You must balance ideal care and feasible care. This requires flexibility and ethical justification in your documentation. Visit frequency is determined by risk level and clinical necessity. Document whether they need frequent visits or not. And the way you do that is show your level of acuity in a case to justify your frequency. Debate framework. Let's now address the great debate in psychiatry. How frequently should we follow patients? Argument for more frequent visits, safety, and early intervention. Frequent contact allows rapid identification of relapse or suicidality. Therapeutic relationship. Regular visits build trust and engagement. We only sometimes have 15 minutes with a patient, but if you spread that over a weekly visits, that's equal to 1 hour of actual face-to-face time within a month. Medication optimization. Early titration phases need close monitoring, crisis prevention. High frequency visits reduce rehospitalization rates. Goal in outpatient is always to prevent hospitalization if possible. An argument for less frequent visits. Patient autonomy. Less dependency fosters independence and resilience. Costs and accessibility reduces financial and logistical burden for patients. Resource stewardship frees appointments for higher acuity cases. Avoiding over medicalization encourages patients to develop non clinical coping skills and community supports. Both positions are valid, and the art lies in applying them contextually. Strategies for a productive debate. When discussing visit frequency with colleagues, insurance reviewers, or even patients, follow 4 steps. Patient-centered framing. Start with, what does this individual patient need? Evidence-based arguments. Reference APA or NICE guidelines for frequency recommendations. Risk-benefit balance. Weigh safety against cost and burden. Ethical framing. Emphasize beneficence and autonomy together, not one over the other. Remember, debates are not competition, they are collective and collaborative efforts to reach the best decision for the patient. The step down model. A pragmatic approach to scheduling is a step down model. Phase 1, weekly or biweekly for acute stabilization. Phase 2, monthly for medication adjustment and consolidation. Phase 3, every 2 to 3 months for maintenance and recovery. If symptoms reemerge, step back up. If stability holds, continuing the step down procedure, meaning extend visits. It's a dynamic process, not a static schedule. Let's go over a case study. Here's a case of a 32-year-old female with recurrent major depressive disorder and generalized anxiety. She initially presented after a suicide attempt and was seen weekly for 2 months. Medication sessions discussed CBT and also was continued on her sertraline at 100 milligrams. After 8 weeks, the suicidal ideation resolved and the PHQ-9 dropped from 22 to 8. The psychiatrist now considers spacing visits to monthly. Argument 1. Maintain frequency visits. Recent suicidality warrants ongoing close monitoring. Emotional stability may be fragile, spacing too early risks relapse. And the therapeutic alliance is still forming. Argument 2. Transition to monthly. Objective measures show stability and functioning is restored. Patient expresses desire for autonomy and less medical dependence. Overly frequent visits may increase anxiety and cost burden. Compromise decision. Adopt a step-down model, biweekly visits for the next month, then monthly if stability continues. Encourage self-monitoring tools, mood charting, provide safety planning resources. And this is how you can debate frequency. So the ethical dimension. The decision to adjust frequency carries ethical weight. We balance autonomy, allowing patients independence and beneficence, ensuring safety. Both principles must coexist, and the best frequency honors patient dignity while safeguarding their stability. Document your rationale thoroughly. Clinical and ethical and practical factors should all appear in your note. And in closing, psychiatric follow-up frequency is not just a scheduling issue. It's a reflection on our philosophy of care. We are not technicians assigning time slots. We are clinicians tailoring intensity to human need. As your patients recover, your goal is to make yourself less necessary, not through withdrawal, but through empowerment. So when debating visit frequency, always ask, what is the safest, most ethical, and most healing for this individual right now? That question, more than any guideline, will lead you to the right answer. This is a topic that's highly debated, and many of my clinicians that work with me and I supervise, I explain to them, usually if you want a cookie cutter way, when you see a new patient, you should see them weekly because you're starting a new relationship with them, building trust, building rapport. And after about 2 months or within 2 months, you can start spacing them to biweekly. And after that, 6 months of biweekly to monthly sessions, you can start considering the 2 to 3 month extension within that year. So the first 6 months, more frequency, and the last 6 months to start to look at a maintenance phase of doing 2 to 3 months. But at any point, you can bring them back if you need to do adjustments or you need to reduce or deprescribe some medication that was initially useful but is no longer. So this can be a very dynamic process, so there's no clear rule. Thank you for tonight.